It looks like we've been joined by quite a few people, so let's kick off. So on behalf of the Global Forum on Bioethics and Research, I'd like to welcome you to this webinar on the crucial topic of mental health research involving adolescents, ethical issues. My name is Katharine Wright from the Nuffield Council on Bioethics in the UK. I have a particular passion for the question of how children can ethically be involved in research to improve their health and their healthcare. So I was very honoured to be invited to chair this webinar. And we have three great speakers today: Pallab Maulik, Rakhshi Memon, and Pallab, and I'll introduce each of them in more detail as we come to their presentations. Just a few housekeeping questions first. So introduction to the seminar itself. As many of you will know, it's the last of 5 seminars in a series hosted by the Global Forum on Bioethics and Research on the broad theme of ethical issues arising in research with people with mental health conditions. And the 4 previous webinars have all been recorded and are available on the GFBR website, so please do have a look at those there. And this webinar is also being recorded, and that will be available in around a week's time in the after today's session. In terms of housekeeping, we'll run the 3 presentations straight after each other, approximately 10 minutes each. Please do put questions in the Q&A while you're listening to the presentations as they occur to you, and then we'll scoop all those up in the panel session at the end. If you see questions that other people have put in that you particularly like to hear answered, please do like or tick those, and then they'll jump to the top of the queue, and I'll bring those in earlier. I can see people saying hello in the chat, which is great. Please use the chat for that kind of communication, or to raise any technical issues you might need to raise, and use the Q&A just for questions. That's the one I'll be monitoring. Let's, without further ado, let's move on to the presentations. And our first speaker, I'm delighted to present you Pallab Maulik, who leads the research department at the George Institute for Global Health in India, and also holds an associate professorship at the University of New South Wales. Pallab trained as a psychiatrist at the All India Institute of Medical Sciences in New Delhi, and received training in public health at the London School of Hygiene and Tropical Medicine, as well as Johns Hopkins School of Public Health, where he pursued his master's and doctoral training. Pallab has worked with the World Health Organization on Project Atlas and other mental health programs, and clinically as a psychiatrist in both India and Australia. His particular research interests include the social determinants of health, especially mental health services, mental disorders, international mental health, and intellectual disability. Pallab, handing over to you. Thank you very much.
Thank you, Katharine. Can I just check if I'm visible, if your slides are visible?
Your slides are beautiful. Thank you very much.
Thank you. So welcome everyone, and really great pleasure to talk today. What I'll be talking about today is particularly a project of mine, which is ongoing. It's a cluster randomized control trial, and it's ongoing in India in 2 cities. I'll come to that. The project is called Adolescents, Resilience and Treatment Needs for Mental Health in Indian Slums, or the acronym is ARTEMIS. So as I mentioned, it's a cluster randomized control trial happening in 2 cities, Delhi and Vijayawada. Delhi is in the north of India, Vijayawada is in the south, and it has 30 slum clusters across each of those cities. The aim of the study is to test clinical effectiveness and implementation of strategies to identify and reduce depression and suicide risk among adolescents living in urban slums. The main hypotheses are 2. One is that a community-based anti-stigma campaign will lead to significant improvements in behaviors towards adolescents with stress, depression, and increased suicide risk. And the mobile device-based electronic decision support system will help adolescents to seek care for those who are at risk. The study started in August 2020 and will continue till July 23. The main elements of the research are to run an anti-stigma campaign in the community to reduce stigma, to set up adolescent expert groups who will guide the research, and to upskill primary healthcare workers, both doctors and non-physician health workers, or the ASHAs as they are called in India, to provide basic mental health care for depression and increased suicide risk. And this is just 2 images from the areas that we are working in. The more forested area is in Vijayawada, it's a slightly hilly terrain, and the other one is in Delhi, which is in the plains, and it's both are urban slums. So what we are trying to do is maximizing impactful research and to do it properly. And to do that, it's very important to conduct community-based translational research, especially in mental health. And it's very important to capture what the community wants. It is extremely important to be mindful of existing mental health resources. And we have made it very clear that we are not planning to use any artificial resource into our system, which later on after the project ends will not be available. We are also looking at focusing on task sharing and training primary healthcare workers. A key campaign is how to engage and co-create the activities that we want to do. The co-creation is extremely crucial, and there are adolescents who form our heart of our program. They help us to develop the anti-stigma campaign, and they also help us about how to deliver them. What are the best ways to deliver them? They actually go and deliver them themselves in some cases. So a key element that we looked at was to do a formative research and to build our understanding of what is a culturally relevant interventions that we need to do, co-create a campaign with adolescents, develop the tools along with them in a culturally appropriate fashion, and then to identify, to do focused research to identify local perceptions about mental health and contextualizing them to the local setting. For example, here you can see a bunch of kids doing a play like a drama. It's like a street play that they are practicing. And this we take out into the community and to share our knowledge about mental health. We are also looking at about increasing access, and this is being done by, but there we have faced challenges, especially due to COVID. And one of the issues that we came across, started doing was e-consenting and online interactions. There were also difficulties in engaging with the 10 to 14-year-olds because they don't really have access to smartphones. So we had to think otherwise about how to engage with them using methods that do not need smartphones. We had separate operating processes to ensure that children with physical or intellectual disability are included in our study. And we obviously had to engage with the parents and the larger community through our community-focused activities. We also had to look at other services. For example, adolescents when they report domestic violence or sexual abuse. And for that, we all engage with a separate agency who are more adept at dealing with these issues as per Indian laws. In conclusion, what I could say is that the research that we did needs to benefit the community and should be relevant. And that is what we try to do through our research. It's important to involve the community and key stakeholders here, the adolescents, their parents, and the community that they live in. Yes, COVID has thrown major challenges around conduct of research and also risk factors that have aggravated the issues of mental health in the kids. But those need to be addressed. I would like to end by acknowledging my co-authors on this, Dr. Sandhya, Ms. Sudha Kalaturi, and Ms. Srilata Paslawar, who are researchers on my project. The co-applicants who are not listed here, the funder, which is UPRI MRC, the larger research team that we have, and definitely the adolescents who are part of the study and the focus of the study. Thank you so much.
Thank you very much indeed, Pallab. I think some really interesting themes there. I think we're going to come back to the Q&A, particularly around this question of how we involve young people appropriately in the development of studies and really hear their voices. Thank you very much indeed. So our second speaker is Rakhshi Memon, who is a director at Manchester Global Foundation, a UK registered charitable organisation focusing on global health and well-being and developing research capacity and capability in low and middle income countries. She's a trustee and former chair of the UK Association for Medical Aid to Pakistan, a UK-based registered charity working on healthcare initiatives in Pakistan. Rakhshi also chairs the Ethics and Governance Working Group, aiming to develop an ethics learning hub at the Pakistan Institute for Living and Learning. And this is a Pakistan-based not-for-profit organisation and a major mental health research centre involved in research both locally and globally. She is also a volunteer for Save the Children charity. Rakhshi has lived in the UK most of her life, and after a successful career in the National Health Service, is currently in the third year of her PhD in bioethics at University College London. Over to you, Rakhshi. Thank you.
Good afternoon, everybody. And thank you, Katharine. Thank you for all your help with the slides as well. And thank you, Adrian and Adam as well. I'm really grateful for the forum to give me this opportunity to share some of my research, which is from my bigger PhD thesis. My research ethics theory is to examine the main conceptions of equipoise and apply them to a different cultural context. And the context is Pakistan. Pakistan is predominantly a Muslim country, and about 95% of the population practice Islam. So I'm using the evidence from my cultural analysis and the normative theoretical assumption that religion is part and parcel of the lives who follow Islam. And this will give me an understanding of the cultural, religious, and social aspects, which will strengthen my conceptual analysis of equipoise in the cultural context of Pakistan, and also answer some interesting questions about how evidence, faith, and uncertainty are regarded for talking therapies. The main focus of my research is whether the clinicians recruiting patients in a different cultural context have any preference for one treatment or the other. And if they do, whether they regard participation in a randomized clinical trial as scientifically and ethically important and necessary despite these prior beliefs. So as I said, my case study is based in Pakistan, and it is a multi-center RCT to evaluate the clinical and cost effectiveness of a culturally adapted, manually assisted psychological intervention, plus treatment as usual, and comparing it with treatment as usual for young people in Pakistan. The sample size is 652 participants, but at the end of recruitment, we surpassed this sample. The ages are between 12 and 18, and these are young people who present to their GPs or in clinics, as well as in A&Es with self-harm, and they have self-referred as well. So what we're testing is the effectiveness of 8 or 10 sessions of YCMAP, which are delivered over the 3 months compared to treatment as usual. Our study will be guided with the theory of change approach to ensure that the end beneficiaries are the center, and we center the whole trial around the needs of the end beneficiaries, and they're the key stakeholders in the process. So my main involvement into the trial has been facilitating the theory of change workshops as part of the community engagement work. The trial is actually funded by MRC and is working in collaboration with Western researchers. So I wanted to find out about the perceived Western values by indigenous researchers and what the differences were in order to go forward and develop a researcher's cultural protocol for before actually the start of the trial. I also wanted to assess clinicians within the trial as well as clinicians outside the trial, which intervention is preferable to them and whether there is justification to conduct the trial and whether we do have uncertainty within clinicians. So some of the ethical issues that were highlighted is which conception of equipoise is morally appropriate for YCMAP. We found that majority of health professionals considered YCMAP as an effective treatment for young people. There was also consensus on the need to conduct an RCT, and that was mainly around reducing bias. There also seems to be enough evidence of uncertainty and the existence of clinical equipoise as moral justification for conducting the RCT. Individual level and theoretical equipoise was not considered ethically necessary, but there was a requirement by the clinicians who were surveyed that cultural, religious factors and other nuances when gathering local evidence base was necessary. So another ethical issue was individual consent may be regarded as less morally important than it is in liberal contexts with families making collective and patriarchal decisions. So to what extent should individual consent be imposed by researchers, as we were following mainly the Western bioethical principles? So this was very interesting. The role of the family in obtaining consent and providing treatment and also as caregivers to patients remains pivotal in the context of Pakistan because of interconnectedness is valued above the moral self. Researchers that I interviewed were also, they emphasized the importance of shared decision-making in Pakistani families. Accepting decisions made by the elders was considered as a matter of respect by younger people, and the influence of elders is propitious to their lives. How can YCMAP complement rather than compete with cultural norms, especially the role of religion and spiritual guidance? It was very interesting, but not surprising to find that religiosity was a golden thread that ran along the themes of the cultural analysis. Spiritual advice was often the first point of contact for patients rather than coming to the health services. There was no restriction on accessing spiritual guidance. So when I talked to the clinicians, they actually supported that, making professional psychological therapies an addition rather than a substitute for spiritual support. The concept of dawa and dua, medicine and prayer going hand in hand as part of part of the culture to promote compliance and engagement was really, the clinicians really wanted to do that. Should cultural values which are incompatible with human rights be respected and accommodated for research? I mean, that was a question I thought was important to raise. The role of the family poses limitations towards individual autonomy in a society where interconnectedness is valued. However, the cultural, religious, and social aspects of a conservative society is a hindrance on individual autonomy, particularly for women and girls to access health. There were also issues of confidentiality and privacy, and women not being allowed to consult the medical profession on their own. Also, the societal denial towards mental health and it being a stigma is the notion that it wasn't, healthcare is not required and is a huge barrier. Also, self-harm and attempting suicide being a criminal offense is an immense barrier to seeking help. So based on these emerging findings, the clinical community in Pakistan regards RCTs underpinned by the ethical framework of clinical equipoise as a gold standard to develop homegrown evidence base. The homegrown evidence came up over and over again. Thus far, the research data suggests it is important to acknowledge and recognize the differences in cultural, moral, and social beliefs and values of a different societal construct. So I do have some recommendations, and these are more research needs to happen in the cultural context of Pakistan so that we are able to capture all the psychosocial, emotional, geographical values and circumstances of the indigenous people. There is also a need to acknowledge the value of keeping the families engaged and for supporting and ensuring compliance. But at the same time, it is important to raise awareness and training on the rights of mental health issues, in particular for women and girls. So education and empowerment is really, really important. A positive drive for the health professionals to work with faith healers, religious leaders, as well as policy and lawmakers is required. Some of the means of raising awareness, and as Pallab also said, and reducing stigma would be engaging community leaders, religious leaders, schools, colleges, and also using social media and television as a channel for health promotion. Engaging policymakers by providing locally produced evidence-based was very, very important, and to put political pressure on policymakers so that self-harm suicide is decriminalized, as well as to improve mental health care services. And these are some of my references. Thank you so much.
Thank you very much indeed, Rakhshi.
Thank you.
And let's move on now to our third speaker, and then we can come back and start debating some of the, I think, some very interesting common threads that are emerging in these presentations. So our
sorry, have I stopped sharing? Sorry.
You have, thank you, Rakhshi, you have.
Sorry. Yeah, thank you very much.
So our third speaker is Pamela Garbut, who's professor and researcher at the School of Psychology in the Universidad Autónoma de Querétaro in Mexico. Pamela has a PhD in community mental health from the National University of Lanús, Argentina, and a psychology degree from the School of Psychology at the University of Buenos Aires. She also has an advanced certificate in research ethics through the International Consortium of the CREI program, with funding from the Fogarty Foundation in the US. She's a member of the National System of Researchers, CONACYT. She specializes in public health, mental health, and scientific research ethics, especially in the areas of childhood and adolescence. Pamela, I'm looking forward to your presentation. Thank you.
Thank you very much. Hello, everybody. I'm very grateful for the opportunity to be here today. And I would especially like to thank Katharine for her support in the preparation of my case study and my presentation. Thank you very much. Okay. Research ethics in an epidemiological study of adolescent mental health in Mexico is my case study. About the research project, it was a cross-sectional epidemiological observational study. The aim was to describe the prevalence of depressive symptomatology, suicidal ideation and attempt, and drug use in public high school students in 2 municipalities in the state of Querétaro. We thought to determine whether certain psychological and psychosocial factors such as self-esteem, locus of control, impulsivity, coping response to family stress and everyday stress, the relationship of the adolescent with her or his father and mother, and support resources and social demographic data would have a predictive relationship with the mental health variable investigated. The participation was voluntary with parental permissions and consent of the participants. As a self-administered questionnaire was used, consisting of different standardized and validated scales for the Mexican population. The results were stratified by reference to the deprivation of the area in which the school was located. About the research background, there is a close relationship between mental health problems and condition of social vulnerability. Mental disorders produce great cost to families, and conditions of poverty, violence, and lack of opportunity during childhood and adolescence increase the probability of developing this type of disorders. In Mexico, one out of every 2 children and adolescents lives in poverty. Of these, 20% are in extreme poverty. Despite the seriousness of the mental health situations of children and adolescents, there are a few studies on the prevalence of these problems that use social impact as indication of ethical concern in Mexico. About the mental health in Mexico, mental disorders have much early onset ages than in another country. In the years 2013, 2018, almost 25% of the adolescent population was affected by one or more mental health conditions, depressions being one of the main ones. The suicide rate in Mexico has been increasing and is associated with an increase in social unrest. 40% of suicide cases were tied in young people between 15 and 29 years of age. The rate in these populations being 7.9 suicides per 100 young people. The figures of alcohol consumption in Mexico are in the rise. Alcohol is responsible for 6.5% of premature death and 1.5% of the days lived in poor health. 41.9% of boys and 39.4% of girls in secondary school have consumed alcohol at some times in their lives. And in the percentage of secondary school students who have drunk excessively was 14.5%. Notably, in primary schools, about 17% of the students' populations reported having tried alcohol, and 2.4% of students reported heavy drinking. The ethical issues about the research. Maximize this impactful, locally relevant research. Relevant and ethical research with a local perspective in social impact can be maximized through the involvement of decisions makers, in this case, education and mental health. The State Education Authority was called upon to advance the proposal, and support was requested from the State Center for Mental Health. It was an epidemiological study with a strong local component that seeks to impact on improving the mental health conditions of adolescents. The training and subsequent involvement of undergraduate and graduate students in research team students of this type is feasible and relevant too. Engagement and co-creations. Decisions makers must be called upon from the beginning of the study, designed not only to obtain full access to the institution and to the study population, but also to have the results obtained as input into their care practices for the specific population. In this case, the collaboration of the middle management in education in each municipality was what facilitated the opening and support of the school directors. The transfer of the results to the decisions maker made it possible to establish action between the team and the State Education Authority to work between sectors to prevalent problems detected. Capacity. Adolescents have right to participate in research that take into consideration situations that especially concern them, such as their mental health. An obstacle during the informed consent process in our students, more parents than expected did not authorize their children's participations, even when their child did express their assents. What about the respect for the principle of autonomy in this kind of situation? The invitation to participate in this type of study can promote autonomy. We have to involve parents more effectively in the consent process to reduce the stigma of mental health problems and to encourage the autonomous participation of the adolescents. Organized activities such as work with them could help. About conclusions and recommendations. Mexico is a middle-income country with high inequality. It is also a country with high prevalence rates of mental health problems with an increasingly early onset. Encouraging studies on Latin America adolescent mental health is a social setting, in a social setting with high rates of violence is extremely necessary. Ethical epidemiological research with a local focus on mental health issues with adolescents in such adverse contexts should be a priority for researchers, founders, and decision makers, especially those whose goals is that the results are input for the design of specific actions for their improvement. To achieve this, it is recommended convene decision maker from the beginning of the investigative process. Encourage the participation of this very specific population is a challenge for the ethic scientific research. It is very necessary to promote mental health study in a group whose ability to take decisions is being questioned, including studies involving the development of ethical knowledge about the characteristics and implication of their participation. This is why it is recommended. Incorporate in the procedures the time necessary for the information provided during the invitation to participate to ensure autonomous acceptance or rejection by the adolescents through their assent. Letting them know that their opinions count, promotes the development of the capacity of autonomy. Parents and guardians should also be invited to reflect on the benefits of their children's participation. Thank you very much for your attention.
Thank you very much indeed, Pamela.
Okay.
And if all the panel could put their cameras on, then we can move on to the panel session. Thank you. Well, thank you all three of you for three fantastic presentations, and I think some really interesting common threads where I think all three presentations were going in broadly the same direction, and then some really interesting ones where I think very different approaches were taken, I think particularly around consent and young people themselves, and I'm seeing questions coming up on that. I was going to use my chair's prerogative to start off with the question of my own before moving to those in the Q&A. If I could begin, I think, by going back to Pallab and picking up your reference to your adolescent expert advisory groups, which I just found so exciting. And I wanted if you could just say a little bit about how you set those up, what the challenges were, and then it'd be interesting to hear the other two speakers reflect on whether similar approaches might or might not work, or what the challenges would be in different settings. Thank you, Pallab.
Thanks, Katharine. I think that's an important question, very important question, and I really see our adolescent expert advisory group as the heart of our program, even if everything else doesn't succeed in the program at the end of 3 years. What we have got and learned from this group, I think, is paramount. Why I say this is because it took us a lot of time and energy to get this group together. First, if you realize we are in two different cities which are vastly different. Different languages, different cultures, everything is different in the two cities. So we had actually two different teams working. So one in North India, one in South India. In North India and in both the cities, we were actually lucky enough to have some partners who had prior engagement with adolescent groups through their activities. So that helped us in at least getting a foothold about engaging with adolescents. But none of these groups had actually worked in the space of mental health. They were more in the space of sexual health and those kinds of infectious disease, that area. So we had to talk to the kids, their parents, get them to consent and come on board. We also are looking at the ages between 10 to 19. So we had to have separate groups for the older adolescents, the 15 to 19. And there again, we had to have it by gender. So males as a separate groups and females as a separate group. But the younger ones, the 10 to 14, we could keep them as one group. And so essentially, we have now 6 AEAG groups across both the cities. And each of those groups have close to 10 to 15 adolescents in each of those groups. And they have been just fantastic, I must say, and really have taught us a lot. Because historically, we started this program on the back of an adult program. So we had done the anti-stigma campaign and we knew how to roll it out. We had been doing it for the past 7 years. But the adolescents taught us how to do it for them. And that is, I think, important.
That's fabulous. Thank you very much, Pallab. Rakhshi or Pamela, is there anything there that you can imagine translating in similar ways in your own studies or in similar ones in the future? Who would like to come in first?
Shall I come in first?
Please.
Pamela,
please.
is that okay? So YCMAP trial also has a youth advisory group. I don't have so much involvement in it, but in the theory of change workshops we had as well. It's really initially important to gain the trust of the parents and family, so that because the perception really there of the elders is that because of their age and perceived lack of experience, that they may not be able to give valuable input. However, when you engage the parents and grandparents at times as well and get their trust, then it becomes easier. So we also plan to at the end of the trial to have a lessons learned focus group with the young people as well. So we're hoping that would be helpful as well. But it's as Pallab said, it's not easy, and you do get challenges on the way, but the researchers, once they can get the trust and engagement and respect, then it can happen, and their input is very valuable.
Thank you very much, Rakhshi. I think this idea of you don't just go straight into young people ignoring parents, but you have this approach that includes families and builds trust. Is a really, really helpful way of indicating ways forward. Thank you. But Pamela, would you like to add anything?
I think the main challenge is respect and recognition of cultural difference, and know that this is not just a methodological issue, but also an ethical aspect. So I think assuming that all adolescents have the same living of development condition is a mistake, and the adaptations and of the intervention should not only be based on the language, but should also consider the social determinant of mental health in each region. That's what I think about the design and yes.
So there can't be a single approach to worldwide and how one does this. One has to find a culturally appropriate way of making sure voices are but in ways that are acceptable. Yeah. Thank you very much. Now, turning to the questions in the Q&A, I wanted to ask one of the first questions that came in, which was, again, it was to Pallab, I think because of the first speaker, but I think it'd be applicable across the board, asking what community leaders you targeted and how you did it, any sort of challenges or takeaways. And I think this is a really interesting theme across all three presentations. One of the things I was so pleased to hear you all emphasize was how ethically important it is that research is actually going to have an effect on the community and make a difference in practice, be implementable. Because I think sometimes we think about ethics as being these very narrow things around consent and so on, which are important. We don't always look at that bigger picture. So I think this question, it arose across all three of your presentations about how you appropriately involve communities to make sure you're asking the right questions, but also to make sure that what you're doing can then feed into practice and make a difference to people's lives. So again, sorry to pick on you first, Pallab, but I'll make sure I don't do that next time. Would you be happy to say something about the community leaders you targeted and whether there were challenges, how you did it, what the takeaway advice would be for others?
Yeah, actually, community leaders that we looked at were definitely the municipality ward commissioners who are there, the village, the elders in the so-called elders in the community, whom the adolescents themselves who identify that these are some people that they look up to. We could also, through our partner organizations that we had on the ground, identify some key members, be it doctors, be it other people in the community whom they felt were key individuals that we should be speaking to. Having said that, I must say that we are still at a very early stage of the program. So the actual larger intervention will only start later next year. So we are still in that formative phase where we have really looked at smaller samples and smaller areas to look at. But definitely, even for any kind of data collection, you need to take permission from the local ward, local commissioners who are there, definitely speak to the family members, and all the ethical consenting, assenting that needs to be done, that definitely needs to be done alongside everything else.
Thank you very much, Pallab. Pamela, would you like to come in on that? I think you very strongly emphasised the importance of working with both the health and the education sectors to make sure that what you were doing was going to be embedded in future.
Yes, I think it's important to incorporate community and participatory perspective from the study design, because adolescents should feel that their participation is very important to improve their mental health, just not to participate in a study. They should know that their opinion and experience are key elements in improving their mental health care. For that reason, study with local perspective are the most appropriate because its results can be input for improving mental health practice that has a meaning for the population, in this case, adolescents.
Yeah. So both the participants and the wider community see those of research involvements. Yeah.
Yes.
Rakhshi, would you like to add anything on because again, your project involves this careful engagement with local communities?
Yes, so I mean, the research center I'm working with has quite a track record of doing community work with communities, and also really collaborating with local voluntary organizations as well. So very much, yes, the community champions, the religious leaders, as well as schools and teachers as well. As I said, I mean, Pakistan being a sort of a country based on, formed on the basis of religion, religiosity goes through, and also the first point of contact being spiritual healers and people going to shrines. So now the health professionals have started engaging directly with shrines as well, and working in partnership with them. And it's been problematic to start with, but as they've again collaborated and worked together, then there are examples, particularly I saw in Lahore, there are some good examples where they're working with shrines as well. So very much, you know, just going back to looking at the context and the social religious sort of context and how you can do it. Very much also, again, making sure, because in Pakistan, it's an Islamic country, people pray 5 times a day, making sure that you're not going when it's time for the prayer and things like that. So just being very wary of your context in community engagement.
Thank you very much, Rakhshi. If I could just jump on actually from all the things you were just saying there, because I think I'm really interested in this intersection between religion and healthcare and professionals. You said, and when you were working with the shrines, it was problematic at first. Why was that? Was it a sense that these are 2 separate things that shouldn't come together?
It was problematic to get that engagement, and also from I think both sides, the clinicians are very much trained in a very biomedical model, and you know, so but then again, there are some prior beliefs and values which are ingrained in them as well, and they themselves, you know, are very much for some spiritual religious therapy side by side to psychological therapy. So I think it's just initially, I think it was a novel concept that you could work together, but more and more, the more work's happening, I think quite a lot of work is happening in Pakistan, where you are engaging religious leaders as well, because obviously the general public would listen to the imam more, you know, if he would say that this is good for you to go and take help. So it's very interesting.
And in case of both healthcare professionals and religious leaders actually being each other and look for areas of common concern. Yes.
And at the same time using the media as well, you know, to make sure that raising awareness, the media is aware, and you know, taking the evidence base to the policymakers.
Yes, absolutely. Thank you. So we have a question now. I mean, again, targeted to you, Rakhshi, though I'd particularly like to bring Pamela in on this as well. So asking about informed consent. So for the question is informed consent from family members enough, or is both parental consent and child assent required in your research? And then the questioner asks, we too share similar issues in Indian settings, but we're mandated by law to obtain both in similar situations. So it'd be interesting to know what the law is in terms of both parent and child consent, and also your reflections on that from an ethical perspective.
I think legally, as far as I understand, legally the consent is the same, but because these are adolescents up to the age of 18, so you would require parental consent. However, in my research, I have seen that they are taking the family consent, the parents' consent, as well as making sure that the young person is understanding as well, you know, at the same time. And a lot of the times, the professionals have told us that they would try and sort of see the patient, if you like, the person first on their own, and with the agreement of the family. So the agreement of the family, the consent of the family is very much very important, crucial, and imperative. However, for signing the forms, etc., you know, up to the age of 18, it has to be the parental consent anyway. But as far as I understand, there is legally, I think assent is in there.
Right.
Yeah.
So in law, basically, whatever a child thinks, it would be possible to go ahead on the basis of the parents' consent.
Parents' consent.
In practice, I'm guessing researchers would be more nuanced than that in being sensitive to
the child's needs as well, and their consent, because they also feel it instills rapport and trust.
Yes. And I think that really highlights the professional responsibilities of researchers, doesn't it? That
Yes.
if the law allows you to go ahead, for example, only with parental consent, there are perhaps ways, if you're feeling this child isn't comfortable, is being pushed into it, are the ways that you can make sure they don't take part. But a difficult seesaw. Pamela, would you like to come in on that in the context of Mexico? I think I'd be interested to know, in Mexico, is it possible for a child to consent without their parents' agreements? Because that was an issue you raised, obviously, if the parents were being gatekeepers and they weren't being allowed.
I think this is an example of how legal sometimes leaves gaps between legals and ethical. Yeah. Often we are forced to comply with the request for ask the informed consent from the parent, even when we thought that the adolescents are able and interested in participating.
Yeah.
And even when we think that the participations encourage the development of autonomy, which is another content of the study as well, which is another output of the study as well. So I can say that the law says that you need to ask for the parents.
Yeah.
But there is a lot of studies and jurisprudence, I don't know how to say it in English, that explain that the adolescents can take care for their interests, their health, mental, and they can take opinion about all of its concerns. But it's difficult when you are in an ethical committee or when you are evaluating, if you don't see that there is a participation of the fathers, you know that it will be a problem. So research, we are in the tension of seguir con attend the law establishment,
yeah,
but to with the ethics position.
Yes, how you navigate between these two things. And I mean,
exactly.
Your final slide, or one of your final slides, you were talking about working with parents to educate them as to why it's important. And that's one
exactly
work within the law, isn't it? To get that shared. Yeah.
Yes, because it's a cultural issue too, that the adolescents can't say a word about their body, their feelings, because it's an issue of the adults, of the parents, and they know about it. And that's a problem, and that's a stigma too.
Yeah, yeah. And there is this strange idea that somehow at 16 or 18 or at 21, whatever age it is, everything changes overnight. And we know in practice, exactly, people are evolving and changing, and things don't change overnight. Particular birthday, it's a much more gradual process. Thank you. Pallab, would you like to come in from an Indian perspective?
So in India, by all ethics committees will definitely want an assent for adolescents who are below 18 years. So even if the parent is giving a consent, you have to take an assent, and the assent can go down even to a 10-year-old if you feel that the assent that you are getting is based on information that you have understood and you're providing it after understanding what you had said to them. So there is no lower limit to the age of where you can need to get an assent. So we do that for all our research. And for even the 10-year-olds, we explain to them and try to get an assent from them that they agree to that. I think the larger question that happens, and I think it's related to one of the chats that was there, was about where parents are not allowing the kids to go and seek care from the primary healthcare center. And we have at both sides of it, at least in the formative work, we saw both sides, where the parents are not allowed, or in the other cases where the kids themselves have not expressed any wish to go and seek care. Here, I think as researchers, our hands are tied, because there is as much as you can do, and beyond that, you have to be governed by ethical laws and principles. So if the parent has not given you consent, it's not just not there. You cannot do anything about it.
Yeah. And I think that really illustrates why the work that you've been doing on stigma is so important.
Yeah, exactly, yes.
Hesitations for allowing children to come forward for care. Yes, thank you. Another question about consent, and again, directed initially to you, Rakhshi. Abhishek Ghosh says, Rakhshi, I echo your findings and impressions. Do you recommend some changes in the informed consent process in view of the interconnectedness of participants and their family members? And was the interconnectedness sex specific? So did this play out differently for girls and boys?
Yes, I mean, all the sort of data that I'm analyzing, there is more and more involvement of the family and the cultures collective. The religion also sort of promotes, family being pivotal. So it's so ingrained into the social cultural aspect of the society and country that I do feel that some kind of the very sort of stark, rigid individual autonomy doesn't seem to be working. I mean, the jury is still out for me as I'm doing this research, but I think that we need to modify it so that there is more sort of inclusion, if you like, of the family into the consent process. That's what my feeling is, because it's quite important. But even before consent, I feel, a step before, as Pallab said, the larger question is the access, if because of stigma, it's just swept under the carpet. People are not accepting that their child or, a young person or anybody has got any mental health issues. There's such a stigma that the acceptance is not there. So both ways, but I think we can't transpose Western bioethical principles into a culture which is so ingrained by social and religious sort of traditions and customs. That maybe I'm copping out, but that's where I'm up to at the moment.
Well, I think it's interesting in that within more Western systems as well, there's an increasing idea of relational autonomy. So the idea that actually within families, however independent and autonomous we might regard ourselves, we still think about talking to our partners, to our parents, to our children about decisions that affect us. And that doesn't mean they control that decision, but what they think and how they react is actually important. So I think we need to reflect that in both directions and just think, no person's an island. We do all exist within families, and
so more consultation, maybe. More consultation and doing it together rather than imposition. So some places there is. It can be quite patronizing from a almost a feminist stance, I feel that there is a more need for empowerment of women and girls.
So I think that there is this tension, isn't there, between the person at the heart of the research and making sure they're not being pushed into doing something they don't feel comfortable with, recognizing that decisions can legitimately be made, you know, in a more interconnected way. Thank you. Pamela, Pallab, would you like to come in on that at all?
It's open. In our study, many parents said that their children did not have mental health issues, and they didn't want to evaluate it, even so it was not an evaluation, a psychiatrist or psychological evaluation, but an epidemiological study. It took us a lot of more time, and we talk to teachers, we talk with parents, we talk with the directors, but also we talk to the adolescents so they could share their interest in participating with their parents and get their permission. This is because we believe that that kind of actions really promote autonomy, progressing the development of autonomy. And that is something more important than the study, in fact. So for many adolescents to be asked about things that they care or that nobody ever asked him how he feels and what can he do about what he feels, it was a very important situation, because we are in a country, in a state that has a lot of barrier of access to health care. So that is very important too.
And so many important themes there. I think that really strikes me as one of the points you actually made in your presentation was about having the time to talk to parents, the time to work with adolescents. And I think there are two things that strike me there. One is about your understanding consent as this process. It's not just the one-off getting a signature. It's about being able to work with children and their families and encourage them to make the case to their parents. And interestingly, in our own work with children and research, where we partnered with colleagues in Kenya, this idea of sitting down together with a family and the young people persuading their parents was a really common theme. So a sense of how within families, perhaps things can be more flexible than one might expect first. But the other thing that really struck me in your presentation when you mentioned about time, Pamela, is is it in your experience, do funders allow you, expect you to give you the time and money to have those extended conversations? Because it's a real challenge in a research timetable, isn't it? And yet it's so important.
Yes.
Is that something you think funders understand?
I think it's something that we need to planificate with more details, more times. And it is something just more important than the questionnaire application. It is really important. It is something that we can make a difference in the community with that adolescent. And yes, I would like to have more time, more money to do more studies to can do that difference, no? Always with that local perspective.
So something we need to make the case for in funding applications, that actually you don't just go in, get the signature and move on with the research, that you need this with wider communities and with young people themselves. Absolutely. Thank you.
Thank you.
So moving on to some of the questions in the Q&A. There's one, what are the ethical issues of Western researchers or researchers of non-Western heritage living in the West, addressing such cultural contextualized issues such as grief, suicide, self-harm, domestic violence, etc., in low and middle income countries? So these issues that they come within medical care, within psychiatric care, but they're so culturally influenced. What are the challenges there when one's crossing culture to work? Would anyone like to pick that one up? I think that's a really good and difficult question.
Would you like me to go first?
Please, Rakhshi, thank you.
Some of the work that I've done with the indigenous researchers, because they do research with Western researchers who come and do some community work with them. So that was why we thought that we will develop a cultural protocol for researchers in order to get a real understanding of some of the differences. There may be customs, or there might be religion, or it might be etiquette. So for that reason, it's getting that understanding is really important. Something as little as eye contact means so different into, say, a culture like Pakistan. If we don't give each other eye contact, it means I'm not being attentive to you and ignoring you. While over there, if you give eye contact, it could be construed especially by the elders, as being disrespectful. So really having a bit of understanding, and then again within the pathways and models of care to make sure that they're culturally adapted is important.
Thank you very much. Thank you. Pallab, there are a whole series of questions for you about the sort of detail of your presentation. I don't think we can go into all of them, but a couple about asking what you meant by slums and what the rationale was for selecting the 2 sites. Could you say a little bit about, effectively both how you identified the sites, and also perhaps a little bit more about the kind of social deprivation or life experience you were particularly concerned with in terms of the adolescents you were working with?
So in India, we have slums which are designated by the administrative units of whichever state you are working with. So we chose it based on that. So it's basically administrative unit defined slums or related clusters. So at times we have something else which are close to slums and not exactly slums, but they have all the bearings of a slum in it because you have not moved out of that. And it's through that and then the whole how we chose it was more about having understanding based on a sample size, study design area. So it goes well, and I don't think this is the forum for us to discuss that those in details. But I think there was one question which was interesting about, and the question asked it whether the research was addressing any of the structural issues about doing the research in slums and doing something about the community. Well, I think a short answer to that is that no, through the research, we are not changing any of the structural issues of the community. I think that's beyond the research that we as an individual can do. I think that's more at a country level thing. But what we are trying to do is address some of the problems that these kids are facing in the slums, the adverse situations that they are going through. Just to give you an example, that one of the areas that we worked in, where we did a formative work, the place, the houses that one of the kids was residing in has actually subsided below the street level. So what happens is that even if there is a slight heavy downpour, water just floods into his home. So the whole time during the rainy season in India, as you can imagine, half the time of the day they spend pumping out water from their home. And so these are some of the issues. And it's very easy to say, okay, this is a more adult problem, so it's not affecting the kids, but it is affecting the kids. And they tell us that this is affecting them, their health. The stress of going through this day in and day out about seeing this, and not knowing whether if I wake up tomorrow, my books are all wet or I have to do something about them. And then the whole issue of COVID is a new elephant in the room, which I haven't even talked about today. So that's definitely there.
Thank you very much, Pallab, and thank you for bringing up that next question too, or linking the two together about this sense. I think it is a real challenge, particularly when one was working in the kind of environment you're describing about, you know, the line between being a researcher and being an activist. And in fact, it's about sometimes research is about producing the evidence that then enables others to take on some more activist roles, and that evidence can help support. But I think in some ways it's a more extreme version of the sort of the ancillary care question, isn't it? When you're doing research and you come across other needs, how do you manage those? How do you support those?
Yeah.
Thank you.
I'll probably just add one sentence, if I may, that what we are trying to do is give some voices to these kids. And that is what through the AEAG, involving them in people with lived experiences, in giving them, we have had some of these kids come and talk at the different international forums also, like one of the kids made a video presentation at the Global Ministerial Summit in Paris last month. So giving them that opportunity to talk, to coach them about doing that. I think that is what we are hoping that at least through our research that we can achieve beyond the research that we are doing.
Absolutely, thank you. Pamela, would you like to come in there? Because I'm seeing some threads with what you're talking about. It's not just the research, it's also about, you know, empowering voices and enabling young people to develop. There's some similar thoughts there.
Yes, yes, I think that is just the challenge, how to involve them. And there is a question here just who asked what were the major challenges and how you were able to overcome them. And I think it is in relation with this kind of question. I think that is the more challenge, how to get involved parents to can work with her child, and how can we do that parents start seeing their child as a growing person, not just a child. And this is a very complicated situation, because it's something that it has to do with the religion, with cultural, with a lot of things that we can control or we can change just for our positions. So we try to develop a demand on the adolescent to start to think that they can, that they have the right to be involved in things that it's concerned, and they have a lot of saying to the community, to the school, to the health service, to their parents. And sometimes that kind of studies just have the function of start that process, no? That they can start to think, oh, they are asking me that, so I can talk about this in school, in classroom, with my parents, with my friends. Because when we finish when they get response the questionnaire, they have directory, a directory with a lot of institutions where they can go to get attention about that kind of things. And there's a lot of that they can go alone. So that is very important too, because perhaps, or in many occasions, the problem is just with their family, so they can't ask them help. So that is a very important thing too.
I mean, that's a lovely illustration of actually how being part of research can be very positive for young people in terms of what they get out of it, in terms of their own development, their own confidence. And actually that takes me very nicely to one of the other questions in the Q&A about whether any of you who studied adolescence have met any challenges getting ethical approval. Because I know historically there's been this sense of research with children, is there a risk of exploiting children? It's something that one shouldn't do unless there's no other way of getting the evidence. And actually we know from a lot of young people how much they value it. So it'd be really interesting. I mean, can I start with you, Pamela, since you're on screen there already? Have you ever had any experience having pushback from an ethics committee about your plans to work with young people, with adolescents?
Yes, I submit my study to the committee, and I presented all the plan to get the participation for the plan to get people to participate in our study. But then, as I told you, we need more time to get that participation because of all of these challenges and obstacles. And a lot of colleagues told me that we could not ask the permission for parents because they were in a school. But I thought, and I know that this could be really very complicated, and it will bring us a lot of problems. We really want to work with community, with family, to understand that kind of point. The same study with the same questionnaire was taken in Ciudad de Mexico with another team, and they didn't have so much reject from the participation from parents as we do. And I thought it is because we work with a school in rural regions than urban. And I think that's a cultural issue too. So I think that we need to do more studies in this kind of schools or community than cities, where everybody has more access to school, mental health care, and a lot of resources, no? So it is a challenge to work with this kind of community that they have a lot of barriers to access of a lot of services. But I think that the result is not just the results of the data research, it's just what is happening during the study in this communication, in this community.
Thank you very much, thank you. Pallab, Rakhshi, do either of you have experience, either positive or negative experiences with ethics committees as to being supportive or doubtful about your approach of working with adolescents. Who'd like to go first? I see you're both off mute.
I'll let you go, Pallab, because you've got more experience than I have. So.
Come on. Okay. You're making me sound very old.
No, I don't mean by age.
Respect.
No, I think our ethics committee were pretty good, and we didn't get any pushback from the ethics committee. But definitely, I can say, and this is quite amusing, is that when I had first applied to UKRI for this funding, they had actually rejected it. And then I had to again touch base with them and understand what the issues were, address all the reviewers' comments and all. And second time around, I got lucky and I was funded. So I think how you build a case at the application stage also matters. And so that's good too. Yeah.
That's a really useful tip. I think about thinking about how we can frame things and explain things you know, to those who might be feeling hesitant about, is this the right kind of research? Yeah, thank you. Rakhshi.
So I mean, the research happens mostly in collaboration with say MRC or UKRI, or you know, so we have to have ethics permission in the UK as well as in Pakistan. So it's doubly, you know, challenging, but what Pallab has said, yes, framing it so and that people sort of think that it's important, the need's really there. And I mean, my sort of most of the input is around theory of change, and we use it as a standard approach to developing our grant applications and doing any studies. And real change happens to real people, and you do need to involve, you know, you need to involve families and others, and you just make a case within your application that this is required. So, so yes, sometimes you get positive results, sometimes you have to persevere and go back again, as Pallab said. So
a message here about being resilient as researchers too.
Absolutely, absolutely.
Thank you. Well, I think we have time for one more question from the specific questions in the Q&A, and then I want to invite all three of you just to say any sort of closing thoughts. But there's one final question I've just picked out, again, targeted specifically to you, Rakhshi, that would be great to hear from any others, which is saying thank you for alerting the cultural concerns when conducting research involving adolescents. May I ask, in your research, do you consider any possible influence of the family relationships when touching the sensitive issue of mental health? So recognizing how what's going on in the family may itself be part of the mental health challenge. And of course, along with stigma and privacy, that's another, this is such a challenging area to work in. So any questions on that excellent question?
Absolutely, because a lot of the data showing that, you know, the family environment, the impact of the family is so much why people, the studies around self-harm and attempted suicide and why it happens. So the therapy is not just for the person themselves, but it is around the family as well. So that's why I was saying that initially, even at the time of consent, you know, and families' involvement and inclusion is so important, so that and it helps with the compliance as well, care, making sure that the family support continues and is there. And that is something so positive, I think, in cultures like Pakistan, is this family support, the support system it positively helps the person to be nurtured. However, at times it can cause complications as well. So the researchers, I suppose they have this responsibility at the time as well to take the family along with them. So, yeah.
Thank you very much. We're very close out of time. I didn't think we'd run for the whole hour and a half, and we haven't. There's plenty more we could have talked about had we had longer. But perhaps in the last couple of minutes, would you each like just to pull out any particular reflections you have, either from your own presentation or from the discussion we've had across the three? Pallab, shall I pounce on you first?
I'm just still trying to gather my thoughts, and I think what I would stress upon is the need to engage with your stakeholders upfront, be very transparent about what you propose to do and how you plan to do it, and then to think with them about how to do it in the most effective manner, and get ideas from them and learn along the process. I think we need to go back and be students ourselves, especially in these kinds of situations, and learn from our stakeholders.
So it's important of it. It's always two-way. It's not just about listening.
Exactly.
It's communicating. Yeah. It's about listening and changing one's own behavior. Yeah. Thank you very much. Rakhshi.
I mean, for me, the important thing is really that we should do more and more research in the context that we are trying to implement our research findings. So and be very wary of those contextual issues that implement, because as I said to you before, real change happens to real people. So however much we can say that this is the pathway, but there are other things that are within that person that and the surroundings that will have an impact. So to be able to be successful in research, I think that's a learning that has come to me in doing research, is that we as researchers have to be wary of the contextual makeup of the place we are conducting research in.
Thank you. That's a real phrase I'll take away with me, Rakhshi. Real change happens to real people and the environment they happen to be in. We can't wave a magic wand and change it, but it's about how we recognise that and support people in developing the services and access they need.
Yeah, absolutely.
Pamela, the final word to you.
Okay. I could emphasize the idea of developing studies with local participatory components can generate impact in the regions, not only in terms of the result, but also in terms of the effect that the development of this type of study has on the community. Giving the voice to those who did not believe that they had a voice is a strong impact. So I think that there is where we have to work. There is where we have to put our effort to develop that kind of studies.
Thank you very much, Pamela. I think it's this idea of giving your voice or supporting the voice of those who are otherwise not being listened to, not being heard, is such an important common thread across all our discussions today. And thank you all so much. It just remains for me to, on behalf of the Global Forum on Bioethics and Research, to thank our three fabulous speakers. Thank you very much for a really, really interesting hour and a half. To say thank you to all our audience for joining us and for your great questions. And to remind you that the video will be available, I think, in a week or so's time on the GFBR website. So please do follow it up, pass it on to colleagues who might have missed us today. Thank you all very much indeed. Bye-bye.